Thank you everyone for joining. My name is Bart Wijstra. We're here at the webinar for unlocking the potential of FHIR for registries. Thank you so much for joining. We're really excited about the amount of interest that was here for the webinar. We have a lot of signups. We have a lot of amazing people. We have great speakers here. I'll do a little short introduction just to know who we have today. We're going to start off with Melle Sieswerda from the IKNL. He is the CMIO there, and he is going to show two amazing projects that I've done with FHIR and combined with other technologies on making the life easier for registries to collect data and to harmonize data. Then we're going to continue with Rien Wertheim, the CEO here at FHIR. Rien is going to take us through the momentum of FHIR, what FHIR is, and also hopefully helping you to make it a bit easier to get started with FHIR in your organization. And then as our third speaker, we're going to Germany to Antje Niedostatek from the Krebsregister in Saxony, and really excited to have her here to give us an overview of their data collection practices and also showing how complicated it is in such a large stakeholder situation and coordinating that. As I said, my name is Bart Wijstra. I work here at FHIR. Rien is going to cover a bit more later what we do at FHIR, but we've organized this webinar because we're really excited about the potential of FHIR, and I think especially in the situation for registries, we think there's a lot of ways that FHIR can help you to improve the data collection, remove the burden from all of your organizations delivering, helping you to get to a higher quality of data, helping you to get to a more real-time situation of data, making the data flow better in all directions. And we hope we can help you a bit to get started on that direction. I have a little poll prepared, and I hope you want to answer that with me so we can get a little overview of what your current involvement and knowledge with FHIR is. If all the technique works well, you should have seen up a Zoom quiz pop up. And the first question is, what is your current knowledge of FHIR? Yeah, please give us an idea so that also our panelists have an idea what they can expect and what the level is that they should speak to. I see that there is a lot of representation of some knowledge, but not a lot of experience using it yet. And some experience using it is good. That's great. I'm going to leave these to run for a while and then turn it over to our first speaker. First, we have Melle, as I mentioned. Melle is the CMIO, the Chief Medical Information Officer, I think, at IKNL, our Dutch pride in collecting data for the National Cancer Registry. Melle is a leading figure in this, and I think the IKNL is also really leading the way with FHIR use in registries. So we're really proud to have them here and work with us. Melle, please take it away whenever you're ready. Yeah.
Thanks, Bart. Much appreciated. I hope everyone can hear me. I should be sharing my screen right about now. Hi. Well, great to see everyone. Well, not see everyone because it's digital, but still. I think that cancer, right, is an important cause of morbidity and death, and that doesn't come as a surprise to anyone here. But if you have the realization that yearly about 20 million people develop cancer and about 10 million actually die from this disease, this is not a very uplifting thought. Still, it is the reason that organizations like IKNL exist. We are the Netherlands Comprehensive Cancer Organization. I should have checked how to click this through because that certainly doesn't work anymore. Oh dear.
It's a shame.
This is funny, but we can fix that in a slightly different way. Right.
We just discussed the difficulties of multiple screens.
Yeah, but I'm kind of surprised that doesn't work.
Yeah, this looks great.
This works. Right, it's a bit better. We are the Netherlands Comprehensive Cancer Organization, and we are a non-profit tasked by the Ministry of Health to collect data on cancer with basically the mission to reduce the impact of cancer. And to do that, we keep the Netherlands Cancer Registry. This is our biggest and greatest asset, and our most important tool to help accomplish this mission. So the Netherlands Cancer Registry is basically a comprehensive national database. It contains currently over 2.7 million patients, 3.2 million tumors. Well, this was in 2023, so it's a bit more now. And we've collected that over a 30-year time period. And we use this data to curate data sets, to support clinical studies, to collaborate on scientific publications, all to improve healthcare, of course. And we also use this to support improving processes in hospitals. So having this important information available is very important to many people. One of our most interesting and recent developments is the Cancer Atlas. All these things, right? And here you can see a couple of hotspots for mesothelioma. This is all driven by the information that we collect and carry. And the way that we do that is basically by curating data from different sources. Now, a number of these sources, such as PALGA or a National Pathology Database or PROMS, which could data sets and vital status, those we can get and obtain automatically. But our most important source, the electronic healthcare records, this is still uncharted territory. So the way that we currently do this is by having a little under 200 people that manually log into EHRs and obtain the data that we need. Now, these are highly educated and trained people. This is by no means an easy task. But if you think a little bit about the current situation, where we have about 130,000 patients a year, and you equate it to working days, you will find that we have about 510 new patients that we need to register each day. And if you look to the future and you think of our aging population, our increasing population, the increasing incidence and increasing data hunger, it's easy to see that this does not scale, right? So we need to do something different. And the thing that we're currently looking at and have been working on for the last 10 years, I think, is to use EHR data as a potential solution. So basically, we want to see if we can get the data from EHRs automatically to our cancer registry. Now, if you want to do this, you need at least two things. And the first one is that you need some way to standardize your EHR data, right? You want to compare apples to apples and oranges to oranges. If you don't standardize, you will get nowhere. And the second thing is that you need a way to actually communicate the information. So if you have that in mind, then there's still two other ways to approach the problem. You can either push information to an organization or you can pull it. For the push scenario, you basically define a query, and then the data that you need is sent automatically to your organization. But this is a wonderful technique and works great. And it's something that many people have used over many years, and also one of the things that FHIR is very capable of doing. The other way is to pull information. And in the pull scenario, you basically define your query, send it across to the hospital, which is on the left, right, and data, the response is returned to your organization. In both cases, you need standardization, just on slightly different locations. So in the first situation, you need it in the interface, in the messaging. In the pull scenario, you need it at the source to be able to determine which data you want to query and want to use. At IKNL, we sometimes have a little bit of difficulty choosing. So instead of choosing for one scenario, we basically suggested to try both and see which one is best. And I think currently we think that each of these scenarios has its own strengths and it has its own applicabilities in different circumstances. So I think we'll continue to do both in the future. I'd like to very briefly take you to one of the projects first and the second later. And starting with Rhonda. Rhonda is the push scenario that we've been working on. And Rhonda is short for real-time hematology data. It's a project that we're doing in collaboration with Performation. Performation is a Dutch organization that has a very good track record in doing data analysis, business analytics, data analytics and stuff like that. But they also carry a piece of software that's called the data gateway. Now, this data gateway allows us to basically standardize the EHR data into their common data model, but the data gateway can also transform that data that we need into a FHIR message and send it across to IKNL. This project is currently in production. It's live since August 24. We currently have about 5 hospitals connected, and I think there's about 15 more coming in the near future. And this, I think the good news here is that this works, right? This is working very well, actually. But we did learn a few lessons. One of them is that we need to start earlier with documentation. This seems to be an ongoing thing and a general truth. For the second project, plugin, we're standardizing data at the source, right? So it's standing data in each hospital that wants to join the project. And the funny thing about this approach is that you are not just tied to queries that you can send across. You can basically send tiny virtual machines over the network. And this opens up a world of possibilities. One of them being that you can send tiny little robots that do AI or learn large language models or do whatever you want and whatever you think is appropriate at the source without necessarily returning all data from the source. So it's a different approach, in a sense, more scalable and more safe. We've just finished. Oh, sorry. Getting ahead of myself. The project that we're doing to basically prove this proof of concept has been dubbed Plugin, and Plugin is short for the Platform for Reuse and Exchange of Clinical Data in the Netherlands. It's a collaboration between 3 Dutch organizations, and here we use FHIR really to standardize the EHR data. The interesting thing about being able to send across tiny little robots is that you get a single infrastructure that you can also use for different purposes, not just data exchange, but also for research and development of AI models. So here too, we've just finished our first proof of concept together with one of the university medical centers in the Netherlands, one in Nijmegen, where we did one use case specifically to populate the cancer registry with a limited set of resources. But here too, we find that this works. I see things popping up in the chat. Is this things I need to worry about?
You don't need to worry at all, but there are some great questions here. There's one question from Udo here. Are the hospitals okay with Sebastian was, are the hospitals okay with you sending them executable code to execute in their environment? An understandable risk. Yeah.
No, this is a very understandable question and a very relevant one. So basically, it pertains to this situation, right? Where you go, this is one too few, where you send a robot across the network to do some magical stuff at the source. The depiction here is simplified, right? I'm just sending across a robot and it works. In truth, there's an entire system behind this that limits what you can do, how you can do it, and it allows hospitals to check what you want to do beforehand. So there's loads of checks and balances happening there just to make sure that you don't do anything stupid. Still, it requires a level of trust. I have to agree. So yeah, in general, this works, and this is, I think it's safer actually than doing the other way around.
Okay, great.
Yeah. I'll get to the other ones in a second because I see some interesting questions there as well.
Yeah, we'll have time at the end also to answer any questions. Make sure you get to your story. Yeah.
Well, I think I'm nearly there. Right. So I think, given the topic that we're talking about, why did we choose FHIR? We discussed a lot of options when we started both projects, and both for Ronda, so the push scenario as for the pull scenario and plugin, we had options, right? For the push, you can even think, should you standardize at all? Well, we think that FHIR still brings a lot of value to the table just by being a standard that is internationally accepted. For plugin especially, I think FHIR aligns very well with the clinical process, which makes it much easier to standardize it and get data to be in the correct format. But I think its major bonus is that it supports both primary and secondary use. So hospitals don't have to choose for one or the other. They can just use, or at least standardize on one interface and have all the benefits that come with that. Of course, there's other reasons as well, but to me, those are the most important ones. So in summary, we are happy that this works. And we also think it's necessary to keep doing this in order to keep us relevant. For a few future steps, right, we're just at the forefront of doing this. There's so much work still to do, but I am already so very pleased with the results that we're getting. And I hope that we can basically collaborate with more hospitals in the future to make this a national thing, perhaps even international. Which wraps up basically what I wanted to tell you. There's links in the presentation, which I'm sure Violet will send out later. But if not, feel free to screenshot and click.
Yeah, we will indeed share all the slides afterwards. Great. And this is how we can reach you. Thanks so much, Melle. That's wonderful. I think there is some time still to get to some of the questions that were asked. I think one question was a relatively simple one. You mentioned a few times participating hospitals. So there was a question: are these all using the same hospital information management system, or are there different providers like Chipsoft and Epic involved?
We want to work with both. So for Ronda, I know we are working with both. The Performation Data Gateway has the ability to standardize both EHR systems to their common data model, so that works. For plugin, we're currently just using the one. We only have a single pilot hospital, which is Rotterdam, and they use Epic. So in a way, that's a little bit cheating because they already have a FHIR API. But for the proof of concept, I think it's still very valid. And we certainly want to work with Chipsoft in the future there as well. Yeah.
Yeah, I think that's actually, I wouldn't call it cheating. I would think that's exactly why we think FHIR is a really good choice, because many forces, and Rien will come back to this, in the market are pushing to FHIR. So hopefully that converges together. Yeah. I think a really interesting question is also here from Björn, more on the side of things, like what motivates hospitals to work with you, like to do these changes. Like there's probably a working system before, like, and they're busy people.
Yeah, very good question. Absolutely. Well, and here I think is where the two projects show their value in a very different way. So for the project we're doing with Performation, the effort that the hospital has to provide is very, very little. They just have to provide a server, and Performation will install the software and it will work. For plugin, right, you need to standardize your data to FHIR, and that takes effort. So one of the things that we're teasing them with is that we're helping them to do that because we think it's important, but eventually that will also make it easier for hospitals to reuse their own data, which I think is a bonus, especially if you look at Dutch other initiatives like things like Cumulus and Health-RI and all these initiatives that really want to make reuse of secondary use of data a thing. And so this is one of the motivations that they're happy with. And there too, you see the distinction, right? So if you're a small hospital, you probably have a little difficulty in standardizing. So Ronda might be more appropriate. If you're a big university hospital, medical center, then plugin is definitely on your radar.
Great. So you really see a combination of both working in the future.
Plus, if they collaborate with us, they get insight into their data quicker. So we help them do data analysis, which is also something that we offer.
Nice. Thanks so much, Melle. There's a bunch more questions, but we have to get to them in the end, or otherwise maybe even follow up afterwards. I want to make sure that there's enough time for the other speakers. Thank you so much so far.
Thanks,
we'll come back to you just before the end. And then I want to move on from this inspiring story of like a leading cancer registry showing how you can work with FHIR, to our very own CEO and founder, Rien Wertheim from FHIR. He's going to go into more detail what FHIR does, but I think he has a great long-standing enterprising experience in using FHIR, growing up with the FHIR specification. He's going to take us a bit more into what the momentum of FHIR is, how it's being used around the world, and how you can get started. Please go ahead, Rien.
Thank you. Thank you very much, and thank you, Melle, for the wonderful presentation. Well, where Melle discussed two projects where FHIR is being used for registry reporting, I'm going to take a step back. In my presentation, I will talk about FHIR in general, the adoption of FHIR, and how registries can benefit from FHIR. Before I dive in, I do have an issue with my voice. I hope it will hold, but just in case you hear me stuttering, it's something to do with my vocal cords. Anyway, so let's see if I can move my slides. Let's see. Yeah, there you go. Is this my second slide? Okay, so first of all, brief introduction on who we are and who I am. We are one of the initiators of FHIR. We've been involved since day one. We're one of the authors of the open source reference implementation, one of the major open source libraries that are out there for FHIR. We also maintain the global platform for FHIR specifier, simplifier.net, which is also being used for the Cancer Registry in the Netherlands by Melle and his team. We also maintain a FHIR API data platform, FHIR server. We jointly with HL7, we run FHIR Dev Days, and I have a slide on that as well. And we are the FHIR trainer since 2013, and I'm one of the founders of the company. Nice to meet you. Okay, so let's dive in. Why standards are becoming more and more relevant? Well, information standards in healthcare, as many of you know, have been around since the 80s of the last century. And in recent years, we are witnessing a growing need for information standards in healthcare. And a few of the causes are outlined on my slide. So first of all, of course, very obvious, the digitization of the patient record, which happened since the early 2000s in many countries around the world. Other factors that come into play, increasing costs and staffing shortages, for which IT and automation and standardization are considered to be a counterbalance for increasing costs and staffing shortages. And then there's also a change in healthcare scenarios. We're moving from a single doctor, single institution care to patient-centered network care, in which the patient himself or herself is one of the stakeholders, in which scenario information exchange is far more important. And let's not forget about the technology trends like APIs, mobile apps, cloud, AI. All of these technology trends lead to a need for more interoperability and connectivity. So why is FHIR different? A few things to keep in mind. FHIR is different from previous, or I should say, current standards for interoperability, that it's based on modern web technologies, HTTP, REST APIs, JSON, OAuth, etc. These are the very same technologies that are underpinning all the apps, websites, etc. that you use on a daily basis. Another thing, discrete data, you can just exchange a single lab result from a single patient. You don't have to parse that lab result from the discharge letter, from a document. You can just query, answer, give me the lab result from that patient, and you'll get it. Very importantly, and I'll come back to that, there's a vibrant global community and ecosystem for FHIR that you can just make use of and get a head start. And then there's a lot of and growing government support for FHIR. I have a separate slide on that. So what are the benefits of FHIR for registries, which is, after all, the topic for today? Well, as many of you know better than I do, the current approach can be characterized by a lot of manual effort, copy-paste, data cleansing, data harmonization, point solutions, etc. And the benefits of a standards-based approach, a FHIR-based approach, can tackle these downsides substantially. Efficiency gains. If you manage to automate and standardize data at the source, or as close to the source as possible, you can diminish the efforts downstream. And once you have automated the data collection process, you can also shorten the feedback loop, even to a degree where you can have some sort of a plan, do, check, act cycle for your data providers. Using standards, using FHIR also opens up a wealth of open source tools and resources, and also expertise, engineering expertise, data scientist expertise that you can make use of. And that's I think a hidden asset from using standards, a standards-based approach. Then already mentioned by Melle, there's also an opportunity to reduce the vendor lock-in, moving from closed data silos to a more open data architecture. And finally, there's the burden reduction for data providers if you can move away from point solutions and reuse standardized data for multiple purposes. Okay, if you're considering FHIR for your use case, for your project, for your organization, you're not alone. In fact, many governments are stimulating the use of FHIR in their jurisdictions. And we see various approaches that can be maybe oversimplified, characterized as the carrot approach, the stick approach, and the effort, grants and subsidies being the carrot, of course, regulation, the stick. And then there's the government taking part in building localization of FHIR for their jurisdiction and in building infrastructure components. We run an annual, jointly with HL7, we run an annual survey to measure the adoption of FHIR. And one of the questions that we ask the participants is, what about FHIR? How is it regulated in your country? And out of the almost 40, we have 31 saying, yes, there is regulation in our country that accelerates or mandates FHIR. So just to give you an idea where the government is moving. And I have a few examples here. The majority of the participants here today from the signups are from Germany, the Netherlands, US, many from Scandinavia, Southern European countries. Germany is taking I would say, is more leaning towards the carrot approach with large funding programs like MII for research and KHZG, digitization, the Hospital Futures Act for digitization of the electronic health record, where interoperability is required, and EZIP for hospitals as well. If you go to the simplify.net website, you can click on the country and you'll get an overview of what's going on in a specific country. The Netherlands, quite similar. Major hospital EHR vendors have limited support or limited support for FHIR. There are government programs in place, METMI, VIPP, and the Dutch government is also engaged in setting core data profiles for the Dutch situation, for the Dutch jurisdiction based on FHIR. US, the 21st Century Cures Act is one of the most advanced pieces of legislation worldwide in this domain, with very specific requirements on FHIR APIs. Same for CMS, the 0057F regulation for insurance companies, and the US government has been funding and initiating the US core dataset for interoperability, which is also available in FHIR. Then NCQA, the Care Quality Organization, nonprofit for the US, especially for the insurance companies, they're doubling down on the clinical quality language based on FHIR to express digital quality measures. It's very interesting developments in the US. At an EU level, we have the European Health Data Space, a major piece of legislation which will not require FHIR. It will leave that up to the member states. But you can rest assured that it will affect more interoperability and more FHIR within the member states. And there are already projects going on for cross-border information exchange, which is partly based on FHIR. Well, if you want to get started with your with FHIR in your organization, here are a few suggestions. Well, first of all, identify a use case with business value, a real deadline, funding, solid funding, and a go live for real users. Quite similar to the projects, the Ronda and plugin projects that we've just seen. Don't do FHIR for FHIR's sake, because then you run the risk of your project being shelved. Once you have identified the use case, make sure to get buy-in and participation from stakeholders in the information chain. You do need commitment when you're talking about interoperability. You don't want to be the only one. Then the implementation itself. Staff training is important. FHIR is different. So lot in common with previous standards, but there are differences. You'll probably do a buy versus build, evaluation, a vendor selection, etc. And then importantly, you as a registry will decide on the definitions of what your data will look like. How do you want your data to look like and to be provided by the data providers? So you'll have to do your own data modeling within FHIR, build your own FHIR implementation guide, the way IKNL has done. Build your data pipelines, make sure that it's secure, decide on cloud, on-premise, local data centers, etc. Those are all things that come up in an implementation guide, in an implementation plan. Now for FHIR training, we have a section on our website, FHIR.ly training. Our most popular training is the FHIR overview training for implementers. The next one coming up January 13 to 15. The next in Central European time. It's the same training, but different time zones, January 27 to 29. We have free e-learnings available on our website for FHIR profiling, which is the data modeling, building your own spec. And then we have an e-learning, the HL7 FHIR summary training, that's also available on the website. You have an excellent opportunity to learn about FHIR and meet the community, June 3 to 6 in Amsterdam. And if you're already involved in a FHIR project, please submit your proposal and maybe you can present your learnings. The call for presentations is open until Feb 1st. And for those who are here for this webinar, we have 3 e-learnings, the HL7 FHIR summary training for free. The first 3 of you to send an email to wat@fhir.ly. And with this, I'd like to end my presentation, give it back to Wat, and I'm available to take your questions. Thank you.
Thanks, Rien. And there goes my my email inbox. Well, thank you for that really nice overview. I think it's probably good if we go straight on to Antje. And I think Antje's really got this from this really forward-looking experiences of Melle. I think Antje is gonna bring us down to the ground and show how it's currently been done in Germany. Really big data collection, not using that much FHIR, considering FHIR, but I think it's really insightful also for everyone else here in the business of collecting data. So Antje, thank you very much for being here and sharing your experiences. I'll just ask you to unmute and then we see your presentation, but not yet in presentation mode.
Yes, thank you. Thank you for the opportunity to talk about cancer registration in Germany. I will therefore first present the general structure of cancer registries in Germany and then move on to my main topic of data exchange. I'm from the Cancer Registry of Saxony, but I'm also a member of the IT network of the platform Paragraph 65C. I'm not.
Antje, I think we're
Yes?
seeing your presentation not in presentation mode.
You know, it's correct. It's correct.
Okay, good. Thank you. Just checking. Good.
I'm not talking about FHIR. In Germany, we use an XML schema as the exchange format. In the future, maybe in FHIR. I'm here to hear from FHIR in Cancer Registry. As you know, Germany is a federal republic. We have 16 federal states in Germany, and cancer registration is a responsibility of the federal states. However, to ensure that cancer registration functions despite the federal structure in Germany, the expert committee platform Paragraph 65C was established. The legal Paragraph 65C SGB 5 regulates cancer registration nationwide. This law is...
Sorry for interrupting. I think you're still on your first slide.
Yes, it's correct. It's
okay,
correct.
sorry.
We are. I want to talk about Platform 65C, our expert committee, and to explain why Paragraph 65C. It's our German law. It's okay.
Yeah, please go ahead.
This law describes the task of the cancer registries. The platform Paragraph 65C has that in itself the main task of harmonizing cancer registration in Germany, creating common rules, and jointly solving the problems involved in implementing the legal task. We have a large number of joint networks and working groups. I'm a member of the IT network. There is also the documentation network. But we also have a billing network for billing the health insurance funds. The health insurance are our responsible for our financial funds. We have in Germany 94 public health insurance and additional private health insurance and different health insurance for civil servants. And this is another term of data exchange in our cancer registry. There are working groups for the formation of the best of, for the classification, for the training of the registrars, and so on. We also have forums where we talk about the software and how to solve problems such as the R forum for statistics. There are 16 federal states in Germany, but only 50 cancer registries. Brandenburg and Berlin here have agreed a joint cancer registry in a state treaty. We have in Germany different tumor documentation systems in the registries, here shown in different colors.
Sorry, Antje, I think we're still looking at the first slides and probably not seeing the one you're sharing. No, we're seeing the screen from PowerPoint, the presentation side of things. Could be that screen where your mouse just went.
Okay, it's good.
No, we're seeing the PowerPoint one where you still see the slides on the left.
No,
yeah, you could
see
click maybe. No, but could you click the little booklet next to the one?
Okay. Now?
No, I think it may be the other screen.
Okay.
Once you started talking about colors, I thought, no, this must be the wrong one.
I understand the question about my slide.
Yeah, now we see the beautiful color. Thank you.
4 years after Corona.
Yeah.
And I have problems.
No worries, that's great. Thanks.
Okay. this is the situation in Germany with 15 cancer registries and different systems in the tumor documentation systems. But what is this next? Okay. What data is stored in the cancer registries in Germany? The content of cancer registration in Germany is based on the oncological basis data set, bundeseinheitlicher onkologischer Basisdatensatz in German. The working group AG Daten is responsible for this and is not part of the platform paragraph 65C. 3 representatives, each from the German Cancer Registries, DKA, formerly GKIT, and the Arbeitsgemeinschaft Deutsche Tumorzentren ADT, and the paragraph 65C platform are the official members of the group. They are entitled to vote. The AG Daten has a large number of members from the German Cancer Society, specialist societies, and patient representatives. They are guests. The oncological basis dataset is used for the long-term comprehensive cross-sector and cross-provider documentation of diagnosis, treatment, and progression of cancer until death by the cancer registries established in accordance with paragraph 65C. The aim is to be able to present and subsequently improve oncological care, quality of care, and cancer in the population through scientific analysis with an appropriate cost-benefit ratio. There's a set of rules on how new proposals are discussed and ultimately finalized in a Delphi process. The final dataset is published in the Bundesanzeiger. This is an official journal of the Federal Republic. The content of the oncological basis dataset are converted into an XML schema by the IT network of the platform. The implementation guide is maintained in parallel with the development of the XML schema. The XML schema is described in detail in the implementation guide and is intended to make it easier for software providers to implement an interface. Here you can see a section of the scheme. In Germany, every healthcare provider sends their oncological treatment data of the respective cancer registries where the doctor or hospital is based in. Each state cancer registries is therefore the treatment registry for its treating institutions. However, each state cancer registry also fully registers all data on cancer patients who live in their respective state. In Germany, many practitioners are involved in oncological care. Patients have a free choice of doctor and can currently still be treated in any hospital of their choice. This means that there are many possible registrars from your own federal state and possibly from other federal states. The issue of data exchange between the registers is therefore essential. This exchange can become even more complex if a patient moves to another federal state. The platform's IT network has given this a great deal of thought. This is a section of our complex description. And every exchange of data between the registry is written in a kind of address book. This is an address book and sample for the address book. The respective registry of residence is responsible for the exchange and, if necessary, also adds reports from other state cancer registries to the exchange. The XML schema for cross-register data exchange is based on the XML schema for the oncological basis dataset and was developed for the interface of this exchange between the cancer registries. There are deviations in the mandatory fields. There is the additional reporting course for information from the death certificate and registration office. There's also an implementation guide for the scheme. In Germany, the data exchange is complicated, but we hope FHIR could be a topic for the hospital, and can make for us it's easier to receive the good data from the hospitals. Thank you for your attention.
Great, thank you, Antje. Really nice. I think, Melle, that's probably a good illustration that we have an easier situation in the Netherlands, being a nice small country without so many provinces. Great. Thank you very much for all panelists. I would like to, Antje, if you could stop the screen sharing, then we can just I'll add all the panelists to unmute and join me in a little discussion. There were some questions earlier. I think, Melle, you probably got to many of them, it seemed. I think you also shared a link to one of your papers. Could you maybe address quickly what that was about?
Yeah, it's a fairly old paper I wrote after doing a project on the hospital where we standardized tumor board report forms, basically with the intention to make sure that the data that's registered clinically is suitable for registration in the cancer registry. And we also evaluated the results of doing that, and it turns out that you can do this properly using the Dutch national guideline as a basis for your information standard without impacting workload. So nurses and doctors don't have to type or click more than they previously did. And it also increases the completeness of the data that's recorded and documented. So it's not necessarily FHIR, although we did use FHIR in that project to get the data to IKNL, but it's more of a standardization works. You can do it if you want to, and it just takes a bit of time.
So in general, standardization, even when the aim was for secondary use, it also improves the primary use of the data and the healthcare.
Yeah.
That's amazing.
Yeah.
That's a great story. I would like to ask you and Antje one other question. Rien showed a little overview of how to get started with your FHIR project and what kind of team you need to get started. Could you address how well, Antje, in your case not with FHIR, but of course you have an elaborate data exchange team already. What kind of roles do you need in such a team, and yeah, how did you get started with that? Antje, could you address what kind of team?
We want to start with a death certificate. This is a great project with from the federal states, and this is our first aim.
Okay.
I think in 2 years.
Yeah, is that the timeline of the project? Okay.
Stefan Lang has developed the profile for the death certificate, and
so the data modeling is the first step.
Bayern, I think Bayern is the first state.
Nice. So you're rolling it out to one state first.
Yes.
Great. How about you, Melle? What do you see as the steps to get started? And
there's so many steps, but they're all tiny. They're all small steps, right? I think the interesting thing about data exchange in general is that it requires so many different specialties or points of view. You need somebody who is medically inclined to understand what the data is that you're exchanging. You need somebody who is able to turn what the doctor wants to record or what the registry wants to register into something that's actually applicable, usable, something that works. And then you also have data engineering people that are able to transform all that data back into something that you can do analysis on. So you really need an integrated team of knowledge and experts, all with different emphasis, right? You don't have to do everything by yourself. I think this is the thing that helps us at IKNL. We have a couple of people that have a clinical background. We have a couple of people that have data science background. We have some data engineering people as well, and that works wonderfully.
Great, great.
In practice, I see people doing this by themselves on their own as well, right? So if you want to, you can.
Yeah, like any startup, you need to start somewhere, and then hopefully you get the experts for every niche.
Yeah, but there's so much documentation online already, right? All the FHIR standard itself is open source, so you can just read it and then try to understand it and get started. And if you don't, there's courses that you can take that are also very quick way to get up to speed fast.
Now, I think one of the points that I would like to make when I talk to registries is always that one of the great reasons to choose FHIR is because your stakeholders, the hospitals that will deliver to you, have already they're already getting pressure from all other sides to work with FHIR as their standard for patients getting access to their data, for exchanging for other means, and you can just hook into that and in that way reduce the burden for them. Maybe, and this is really a question for all panelists, but could you speak to what extent you already see that indeed happening? Are all the hospitals that you're working with, are they starting with FHIR, or is it a specific subset?
Mostly subsets, and what we've seen in several countries is that the use cases are refined to what is nationally aligned on. So the core data sets for certain countries are the starting point for many use cases. That's a safe way, but it's not always sufficient. Like, for instance, the IKNL example has derived data sets from those national data sets, which is kind of step 2. And the EHR vendors also tend to stick to what is mandated or required, for instance, from legislation or from grants and subsidies. They support what is required in those programs and in those regulations. And if you want anything beyond FHIR-wise, then it can become challenging.
Yeah, I think
I'm not sure if that answers your question, but
yeah, I think that's a great question. It also hooks into what Øyvind asked in the chat, and maybe I would like to pose that to Melle too. First of all, indeed, to what extent do you see all your data delivery organizations indeed adopting FHIR? And Øyvind also asked, like, to what extent can you reuse those FHIR APIs that some of these EHRs already have? Is the information that's in there, is it extensive enough? Is the information very different that you need?
Just start with the last thing, because I think that's the most specific and also the one I feel most comfortable with. Yeah. Yes, the Epic FHIR API is, at least as far as I've seen so far, very, very useful and very usable. The things that you're going to run into are not necessarily FHIR related, but they are more process related, right? So in FHIR, you have the ability to document a tumor stage as part of a condition. Now, that works very well in communication and querying, but if the hospital doesn't record the tumor stage using the specific tumor staging form that Epic provides, then it won't wind up in the interface. So there's lots of tiny decisions that hospital makes that have impact on whatever comes out. Same thing with the coding of lab values or results, right? Same with coding of procedures or diagnosis. If your hospital doesn't use ICD-10, you won't get ICD-10 as a diagnosis code. So this is the point where, as a country, I think we should say, this is the route you're going to go. This is the minimum that you have to do. Otherwise, we can never get to any form of interoperability. But that's not necessarily FHIR or Epic related. I think that's more of a national consciousness that should start developing.
Yeah. So use standardized vocabulary from the start. Antje, how about you? How do you see this in Germany, in your region? Do you see hospitals already working with FHIR?
I don't know.
Okay. Yeah. They're not asking you, can we please deliver the data in FHIR yet? No.
I hope so, but in the moment we have with many players to deliver here structural data. Das ist a main topic for us. We have unstructured, we have free text data. This is not that is our topic theme, not FHIR or other.
Yeah. And another question I have is I think it.
Sorry to interrupt you. There's an interesting question about consent. Have you seen
please
it?
go ahead. Yeah. No,
Yeah.
please
Shlomi,
run it.
Well, Shlomi is asking about how do you deal with consent, IKNL and Antje. Let me see where that question is.
Yeah, I see it here. Yeah.
It's a Q&A.
Yeah.
How do you handle patient consent when onboarding a new patient to the registry? And do you also use FHIR for the submitting and storing the consent? Maybe Melle, you first.
Yeah, this is this is a tricky question, right? It's also a tricky answer. As you can imagine, with 130,000 new patients and 530 on a daily basis, it's very difficult to ask each and every patient to provide consent. In fact, if you do that explicitly, you might find that your data becomes biased because there's a group that might say no, and you don't know from the outstart what that group or who that group is. So we have belang. What's the word?
Interest.
We have an interest in keeping this as low profile as possible. At the same time, we do agree that people should be able to say no to this. So the way that this has been put together is that we have, and I'm not a lawyer, so don't pin me down on this one, but there are laws and regulations that say that we can obtain this data because it's beneficial to the population. And given that we don't have to ask each and every patient for consent. And on our website, we provide a way to opt out. So if you go to IKNL.nl and look at the NCR, you will find the possibility to say, no, I don't want this. And if you say, tell us that you don't want to participate, we'll remove you from the registry. So that's the long answer. And the short answer to the question of whether we're using FHIR is no, we're not using FHIR because we're not documenting consent in that way. We're basically keeping track of who opts out. Does that answer the question, Shlomi?
That's until we get an answer from Shlomi on that. Antje, do you wanna cover a bit about how you're handling consent within the registry?
We have obligation to register every patient, but every patient can give a contraindication, and we have in our scheme an item for this. It's it's in German. It's complicated.
Yeah. The Germans are doing the
Germany.
wonderful fight of privacy for all of us.
It's difficult. It's also difficult.
Yeah. I can imagine.
Difficult.
I think
consent is difficult globally.
Yes.
Don't worry.
It is, but also important. We have like 1.5 minutes left. I want to do one more question. And I think some of the organizations that are in the participants may ask themselves, like, okay, the Netherlands and Germany are relatively rich and maybe well organized. How big do you need to be to get started with this? Is there something you could do at any level, or what are your views on this? Maybe for all of you. I'm not sure who wants to jump in.
If I may,
Please.
The interesting thing is that if you're, I don't mean this in a condescending way at all, but if you're not as far along as we are currently, is that you're also probably not that dug into a specific type of technology. So you might face a relatively green field in ways of choosing what technologies you want to use and where. I think that provides an opportunity. In fact, one of the people that's working on plugin with us, Daniel Capitan, did a project in Africa where they use FHIR as a primary data store. And there was no obsolete technology to replace. They just could start with whatever was new. And that works. Still, I agree, it helps if you have money.
Great. I think I underestimate how fast time goes. We have 5 seconds left. I really want to thank everyone for being here, but most of all, I want to thank our wonderful participants, Melle, Antje, Rien. Thank you so much for joining us. We will follow up with all of you by email with the slide decks, with a link to the recording, and also I'll take a look at Melle and Antje. If they're willing, we'll also share some contact details if you want to ask more questions. For now, if you want to reach out to me, you can reach me at Wart@FHIR. I put it somewhere in the chat. And thank you so much for joining us. And I hope we can help you get it one step further to more easy data exchange with FHIR. Thank you so much.
Thank you. Bye-bye. Thank you, everyone.
Bye.
Thanks, guys, for organizing. It was a pleasure.
Great.
Thank you, Melle. Thank you, Antje.
Thank you.